Folks, welcome. This is your Q&A session from the Southeastern Regional Office. We're waiting for folks to join. We have a number of folks from our office on board to cover a number of topics. My name is Gene Matthews. I'm director of the Southeastern Region. You'll see my face in just a minute when I take the slide down. And I've been doing a lot of work with Dawn Hunter on COVID messages in a difficult communications environment. We will have a session on this tomorrow at 12 noon Eastern for an hour. So if you want more on that we don't get to today, we will be covering it then. Dawn Hunter, who is deputy here in the Southeastern Region, was also helping moderate your opening plenary if you were watching that today. And there were a lot of questions raised on health equity, social justice. She'll be able to answer questions on that. And she and I will also be co-hosting a session, networking session of 30 people at the end of the day tomorrow on these topics. Then for those of you that were on the first breakout session today, then you would have seen Corey Davis and Amy Lieberman do work on opioids, access to prevention, treatment, and care for people who use drugs. They're very experienced on that topic. And Corey and Amy will also be hosting a networking session tomorrow afternoon at this same time that Dawn and I are doing the other one. They'll be talking about harm reduction issues. And then Jane Perkins is also with our office. She's the legal director for the National Health Law Program, has deep expertise in Medicaid expansion, access to care, and maternal child health. And also tomorrow afternoon at this same time slot, her colleague, who's also with our office, Sarah Summers, will do a session on Medicaid expansion and maternal child health issues. So that's who we are. These are the topics. I'll let Dawn and Corey and Amy give a little quick blurb on a bit more on what they're doing while you folks are thinking about your questions and submit them into the chat box. And I think with that, I am going to, if I can figure out to do it, stop sharing for now. And we will go back to hopefully everybody seeing Hollywood Squares. Is that correct? Okay.
Yes.
So let me pitch it to Dawn. Do you want to talk just a little more about this morning's plenary session for those that didn't catch it, and sort of where we're going on the Southeastern's assistance to the network on health equity, social justice, non-discrimination in a federal context? Go ahead.
Yeah, so the plenary, if you weren't able to join us, was partly an overview of the political determinants of health. Daniel Dawes recently published a book on the framework. It's also, there are a couple of journal articles out about it. And not just looking at what we call the social determinants of health, but looking specifically at political action and political will as influencers of health outcomes, and looking at as an intervention point. And a little bit of a discussion about the conversation around personal responsibility versus political determinants. And then Charmaine Ruddock, who is with Bronx Health Reach, great information about the work that they're doing there, but really how the community is driving change to achieve health equity and holding local leadership accountable to make changes in their community. In the Southeastern region, if you come to our session tomorrow afternoon, I'm focused on state and local strategies to address racism as a public health crisis. So looking at legislation, ordinances, resolutions, and declarations, and other types of actions, including budgeting and budget decisions to address racism and structural inequities. Jean mentioned messaging, doing that. And I'm also focusing in the lead up to the 2020 election, but probably always, on the importance of civic engagement as a health equity strategy, and why not just voting, but other forms of civic engagement are important to health outcomes.
Okay. Corey, you and Amy want to talk a little bit. Y'all had a very robust session at the 2 hours ago on this, but talk a little bit about what you folks are doing on harm reduction.
Sure, thanks, Jane. Yeah, so we mostly talked about how, we've got these two overlapping epidemics. I mean, you could say three, you could say, with all the issues Don was talking about and that you covered in your session. But we mostly focused on the fact that we have this ongoing epidemic of drug-related harm. And then we've layered the COVID-19 epidemic on top of it. And, all the data is telling us that the COVID-19 epidemic is just exacerbating all of the existing health problems, all of the existing inequities that already existed in the opioid crisis, from people being unable to access the community organizations where they were getting things like new syringes, naloxone, just community. The fact that social distancing is making it less likely that someone who overdoses will be found in time just because there are fewer people around. So there are lots of sort of negative things that have come from this overlapping of these two epidemics. We talked about how the federal government in some states have taken some actions to remove some of the legal and policy barriers to evidence-based practice. The federal government has made a few changes that remove some barriers to accessing methadone and buprenorphine, which are two very effective medication treatments for opioid use disorder, which federal law makes it unreasonably difficult to access. Some of those have been modified during the COVID-19 crisis to make it a little easier to access those medications. So we talked about how that's a step in the right direction, but there's no reason that those should be limited to the COVID-19 crisis. And we talked about some efforts that states have done and can continue to do. So we are happy to, we'll also have a session tomorrow, but we're happy to talk during this session, answer any questions that folks might have about what states and the federal government and localities have done to try to remove some of these barriers to things that we know work, and some suggestions for how to do better.
Okay, Amy, anything you want to join in with?
No, Corey pretty much covered it.
Okay, all right. And so Jane Perkins, there's also, I forgot to say that there's also a session tomorrow morning also, or tomorrow at noon, on some other parts of Medicaid and private insurance as well, on that, done by some of our colleagues. Sydney Watson for one, I forgot the other. But Jane, you want to give a little background on what InHelp and what the network is doing on Medicaid and MCH?
Sure, just focusing specifically for purposes of this session on Medicaid expansion. That's the part of the ACA that expanded Medicaid to adults with incomes below 133% of poverty. A Supreme Court case in 2012 made that uptake of that expansion an option, whereas in the statute it's a mandate. Currently 38 states in the District of Columbia have taken up the option. We've been monitoring research to show the benefit or not of Medicaid expansion. This is a wonderful test tube because you have comparator states, the 12 states that aren't expanding. So there's a robust set of research out there showing the both the health and financial repercussions of Medicaid expansion, which overwhelmingly positively affect health and don't have significant negative impacts on budgets. We're also have been monitoring for the last few years in particular state activities and federal waivers, particularly under Section 1115 of the Social Security Act, to condition Medicaid eligibility for this expansion group of adults on provisions that are restrictive, things like work requirements, mandatory premiums, that you have to do those things to get and keep the coverage. There's been litigation on that in 4 or 5 states. That litigation is now at the Supreme Court. We're certainly involved in HelpIs, and we're monitoring what's going on in that litigation. There's another case at the Supreme Court. Those cases are just at the petition for cert place, by the way, the work requirement cases. But there is a case in front of the Supreme Court to be argued in November, California versus Texas, which is challenging the constitutionality of the individual mandate and asking that if the court finds the mandate to be unconstitutional, the entire ACA would fall. So we're obviously taking care with that case. States have, outside of the expansion context, made a number of temporary changes during COVID. These are sweeping and affect everything from how they're doing eligibility to how services are being delivered. We've been monitoring the vehicles that states use to attain those changes and what those changes are. In the maternal and child health area, the focus has been on oral health. There's a new CDC health policy report looking at laws and policies to improve oral health. And we focus on Medicaid early and periodic screening, diagnostic and treatment services, EPSDT services, across the board, but in particular recently in 2 areas, coverage of medically complex children and children with intensive behavioral health service needs.
Thank you.
And I'm happy to answer questions about that.
Okay. And just to say again, please send your questions into the chat box. There's one from our colleague Julia Kostic and one from Virginia. Let me just say, if you're interested in any kind of technical assistance, this is what the network does 24/7, and we're doing a lot of COVID technical assistance these days. You can submit it to our regions, or you can submit it on our network website, and it will get sorted down. We also do a lot of training on many topics, including messaging, opioids, health equity, maternal child health, etc. I do not see Dawn or Sarah. If you can help me, I see a note that Sarah Kostic had the first question, but I don't know what it is. So if
I can read it, Jean.
Go for it.
So the first question that came in is a question for all of us. And I'm teaching the law school's health law course again in the spring. What are the most important legal issues for law students regarding COVID-19 and related matters?
Me first. I am teaching public health law to doctoral students here at UNC. And boy, is that a hot question. I think I'll try, if I get a moment, I'll post the link to a really good article that was in New York Times Magazine about how the U.S. sort of flunked the COVID test. And the one word answer is federalism, because COVID, from a legal point of view, COVID has exposed the gaps that were intentionally designed in our federalist system of government with checks and balances. And Madison's old idea of let us not put all the power in one center. Let's have it split apart so we don't get rampant emotionalism to carry the country off the rails. And sort of served us pretty good. But in COVID, it's just a textbook case of how COVID and our political polarization right now has just like COVID has expanded structural racism and social justice, it has also exposed and widened these gaps that drive my public health students crazy at the doctoral level. Why can't we just have one federal system of disease surveillance and reporting? Why do we have it under 50 different states? So that's my first choice on this. And again, if I can catch a moment, I'll try to paste in, I'm not sure it's the right chat box, the link to a pretty nice article that goes through our COVID experience, and it shows how federalism has not made us very effective in dealing with it. Now that's my law professor answer. I think I heard myself rant, so I'll shut up. Dawn, why don't you take over? I know you got things to say about social justice and so forth. Go ahead.
Yeah, I would say, I was in one of the talks earlier and they were talking about preemption, and the people who are most impacted by preemption are people of color and people who live in low-income communities, et cetera. So I think that is going to be one important topic, because I don't think that's not an issue that's going away, and in fact, in many ways is getting worse at the local level. I think I also would add that equitable enforcement is an issue. So I don't remember in law school really you spend a lot of time talking about whether laws are discriminatory, but you don't really, spend a ton of time talking about how they're enforced and whether or not that enforcement is equitable. And I think certainly if curricula are not shifting to start to talk about that more, then certainly I hope that you, if you're on this call today, or students who are participating, really lead the conversation around, well, what does this look like in practice? And if it's not equitable, how do we change it? You don't really have those discussions as much, and you probably should.
Okay.
Jean, I have a Medicaid one.
Jump in there.
Yeah, and that is, under the Family First Act, for purposes of Medicaid, there's a maintenance of effort requirement. If you maintain eligibility and services, you get enhanced federal funding. So states are maintaining Medicaid services during the life of that act and during the life of the emergency. But there's, I think, in terms of a law school class or a health policy class looking forward, I know the thing in the Medicaid world that everyone is very fearful of is what happens with enrollment, termination, and due process as the continuous enrollment comes to an end, as states roll off of these steps they've been taking. It could be a massive mess, and would also be a great problem to think through in terms of how Medicaid eligibility and due process is meant to work and is set up on the books to work.
Corey or Amy, anything?
Go ahead, Amy.
I was just going to say, I think that it's going to be an interesting thing for law students and lawyers to think about, especially in the context of opioid treatment. So many rules have been relaxed, and how the government is going to justify pulling them back to where they were, if they choose to do so, which they probably will, and just kind of a look at what is the motivating force behind this law, and is it really backed up by any sort of actual evidence, and or do we see now that this is stigma based or or some sort of structural inequity.
Okay. Corey, go ahead.
Yeah, I would just say really briefly, and this is broader. I mean, I think that we're really seeing the importance of administrative agency action, deference to administrative agency action. I mean, it's evergreen, but we've seen, you know, the previous administration and the current administration very aggressively using administrative action, executive agency action to accomplish their goals. And that's true. That's true in the COVID crisis as well. And it's tied into the importance of, you know, of having science-based, science-driven people running those agencies and making decisions in those agencies. I mean, you know, I mean, I think we tend in law school not to really talk about those sorts of issues, but that's clearly very important. I mean, the system is built on the premise that those administrative agencies have expertise, you know, are acting in the best interest of the people that they're supposed to serve and so on. And, you know, the system really breaks down when that is no longer the case. And I think it's really important just to really clue students into that. I mean, I think that that's something that maybe we think that they pick up along the way, but I think it can be important just to drive that point home.
Okay. Dawn, you want to go ahead and pick a question? I think you've got a better look at the two different chat boxes that seem to have opened up here. Go ahead.
Muted. Okay. So from Virginia, I'm interested in and concerned about how slow local and state authorities resisted and then stumbled to investigate, evaluate, and report nursing home facility COVID-19 incidents. Much misinformation was put forth, I think from or to, not nursing home staff and residents and the public. What, if any, short and long-term adjustments and changes do you see now or anticipate?
I mean, I will take a first stab at that. Part of the difficulty is the skittishness of nursing homes being regulated. And they're sort of regulated at the state level as well as, you know, their Medicare or Medicaid qualifications. And I think early on, there was sort of a reverse self-interest of nursing homes to share information because, you know, they would be, you know, looked at as the a place where COVID was rampant and it would be bad for business. It's the economic factors driving through that. Over the longer run, it's become somewhat more acceptable, but I think that was part of the misinformation of nursing homes early, that it wasn't in their financial best interest to be forthcoming. It wasn't good for their, you know, morale and whatever. I imagine, Dawn, you've got an answer too as well about the whole issue of reporting data and reporting demographics, and I'll let you handle that piece of it. But that was another piece of this, and we're seeing the same thing in universities because they're so freaky about bad publicity and reporting the number of students, and the FERPA, the Federal Educational Privacy Act, that they're not as transparent as they should be. Certainly that's the accusation here for those of us in Chapel Hill with University of North Carolina. So you see those economic and also sort of legal shadows that they're flinching back from, not wanting to violate privacy as part of it. But I'll pitch it back to you, Dawn, on just the whole demographic issue itself.
Yeah, I mean, I would advocate for mandatory demographic data reporting and uniform reporting across states. So one of the challenges that we have, in addition to states and facilities within states not reporting is that we just also don't have consistency across states. So it's hard to compare data across similar populations and know what's really going on. But sometimes we do have really good quality data at the state level. But we want the reporting to be mandatory. We also we want transparency around what their policies are. So what policies they're putting in place to ensure the safety of residents and to control transmission of COVID-19, but really any infectious disease. I mean, really, these facilities are already required to do that, you know, and control C. diff outbreaks, for example. Jean is absolutely right. You know, I've been involved in the regulatory side of this, and the scheme for regulating these facilities is complicated, and the people who staff the organizations, the agencies, often, you know, health or human services, they're often understaffed and underpaid. So, you know, one intervention is to address that issue and make sure that you have staff who are supported to do the work of surveying these facilities. And that there is an incentive to report. And so I think Jean is also spot on in saying that there is often a disincentive to share, you know, bad information, if you will, or something that's going to be perceived poorly by the public because it affects their revenue and it affects, you know, patients coming to stay there. And so we have to incentivize reporting in a way that, you know, people will actually report. I don't know if anybody else has thoughts on that.
Jane or Corey or Amy?
So there's a Medicaid question we can go to. So, and then I have a question that actually came up in one of my earlier sessions that I'll throw out there too for everyone to think about. But this is, can anyone direct me to an issue brief or a resource that discusses the lack of Medicaid expansion in southern states impacted by COVID?
I'm not sure whether the resources have been developed. There is now a group of advocates in southern states that are working to address this, because you put your finger right on it. The 12 states that have not expanded are southern states, with the exception of Kansas and South Dakota. I don't know who asked that question, but I'm at perkins@healthlaw.org. Email me, I'll get you some resources and connect you with the organization that's working on expansion issues in the South. Some of the research as well, just a study just published by, I think, Commonwealth Fund, looked at the expansion and work requirements in Arkansas and compared it with a couple of other states and showed how the effects of those work requirements. So there are some comparative studies with non-expansion and expansion states, and I can get those resources to you as well.
Thank you, Jane. And so while you're thinking of questions, audience, I've got a question that I think everyone can answer. So one of the things that came up in the plenary is this debate between personal responsibility and these social and political determinants of health, and what are the real drivers of health inequities. And I think we see that in harm reduction. I think we see that in Medicaid in terms of like diabetes and obesity and personal choice and work requirements, for example. So, you know, what are your thoughts on how we move the conversation away from, you know, the personal responsibility argument to here are all these structural factors that are driving the outcomes that we're seeing?
Well, I mean, this is Jane. I think those things kind of can't be dealt with in a globe. I think that it's too important to kind of break them down and just take each one on. I mean, just to use work requirements as an example, they cost multi-millions of dollars to get your administration in place before you even have imposed the first work requirement on the first person. There are reports from at least 7 states that show how administratively costly these are. From a policy perspective, the vast majority of people on Medicaid either already are working or can't work because they're have a chronic condition or engaged in childcare. So in most states, you're really looking toward, if you really want to do what you say you want to do, you're targeting about 6% of the population. So you're spending multi-million dollars in the administrative side to target this 6%. So clearly that from a policy perspective is a highly questionable venture. So it really does mean that it's coming from a place of kind of these people should work. And of course they are working, the vast majority of them. And then of course, I think the other point is that every court that has looked at it has found that they are illegal in Medicaid, because Congress said the purpose of Medicaid is to furnish medical assistance, unlike some other programs like SNAP and TANF that have work requirements built into them. Medicaid does not. Research shows that healthy people are able to work. So having health insurance helps keep you healthy. So I think just breaking each of those things down individually is an important endeavor.
Yeah, good point.
Yeah. Corey or Amy, any thoughts like from your perspective?
Yeah, I mean, it's a tough question, right? I mean, in some sense, it kind of comes down to like changing the zeitgeist in a sense, right? I mean, we have, a lot of the Western world in the United States in particular is, sort of built on this myth or this mythos of individualism and the idea that we rise or fall based on our own actions, which is, clearly not true, but is sort of a useful myth for particularly, people who would want to exploit individuals, right? I mean, if you convince people that the only worth that they have is worth that they can, their value on the labor market, creating excess value for other people. Not to get into a little Marxist rant, but I think it's just sort of convincing folks that that's clearly not true. That we all do better when we all do better, and this really is a myth that is being fed to us, to our own detriment. How to actually do that, I mean, this is partly what Jean talks about, how to convince people to sort of act in what we think is their own best interests, which at the end of the day, it turns out that in general, the best interests of one really are the best interests of all, because we're better when we work together, and we're worse when we're fighting with each other. How to actually put that into practice, I don't know. I think that's tough, but I think kind of saying it out loud is helpful, of just kind of, saying, like, this is actually, it is actually the case that, helping other folks, helps you, that we're all in this together.
Corey, I have a follow-up question for you. Can you talk about the effect of COVID on recidivism rates for people with substance use disorder, what we're seeing, and what we might need to do, as the pandemic moves forward and we try to move back to normal to address that?
Well, I mean, I'm not sure that we know much about that. I mean, we do know that overdose death rates seem to be going up. Unfortunately, we don't have great data, but it does seem like that's going up. I mean, we know anecdotally that for a lot of people who have opioid use disorder but are not currently using opioids, people who common term is in recovery. People who are either on medication or in non-medication based recovery. The social connections are really important. It could be, going to some sort of a 12-step program. It could be, talking with a counselor. It could be just meeting up with friends. Humans are social creatures. We want to talk to other humans. And we also, to some extent crave, repetitiveness, right? Like we like to have a routine. And COVID is, the responses to COVID are just disrupting all of that. It's a lot harder to have those human connections. It's a lot harder to see people. So just those sort of normal things that we're keeping people in recovery, centered and grounded and not using or using at a level that they're comfortable with, has really thrown a lot of people into chaos. We suspect, we believe, we have a lot of anecdotal evidence that's happening. Hard data are hard to come by. And of course, we also have, you said it's more difficult to see a doctor to get a prescription for treatment. It's harder to have those interactions with your healthcare provider. If you have employer-based insurance, which a lot of people do, maybe you've lost it. There's just lots of structural factors that seem to be, like that they are bad, for people who are in recovery. Also, we do have data on alcohol sales, for example. And, the data that we have shows that alcohol sales are through the roof. It's a very common, normal response to, to react to stress and to, again, to changes in that routine, by using substances. So, we could have this almost double barrel effect, or we have people who are in recovery who are relapsing, and we have people who may be developing substance use disorders as just sort of a coping mechanism. So, I said, unfortunately, hard data are a little bit difficult to come by, but everything that we know suggests that, it's a big problem now, and it's going to continue to be a big problem in the future.
Thank you, Corey. I have two in the pipeline. So one's a comment, but I think I'll maybe respond to this comment, and then one's a question. So the first is, health inequities in Nashville, Tennessee are baked into the local laws, practices at employers and institutions like health systems, schools, and churches, as well as state legislation. Last week, one woman told me, "We can't wait for them to all die before change can happen, yet that is their expectation. The time for change is now." So that is not a question, but I think we did get a question in the plenary, and certainly in some of the breakout sessions, which is, the time for change is now. What does change look like? What can people do? So the folks who are in our breakout session, if you had to give one thing and say, go do this, or go make this happen in your community, what is that thing?
Well, I will again pitch it back to you. I mean, go vote. Okay, that's one thing. All right.
Go vote, yes.
And maybe on that note, Dawn, if you would just give them the quick, in a minute, give them the quick piece about how voting relates to health and well-being as well, how civic engagement, because that, maybe give them the link to the paper, that the blog that you did, because that's really relevant on this. But I mean, historically, there's a deeper issue at play here, as after the Great Depression, the stock market fall, all of that, it took a while, but there was really a change in the social contract in this country of the safety net and how we do healthcare and how we do how it's all functioned. And that was done like in the 1940s and 50s. And that system is it's been broken for at least 2, maybe 3 decades. So we are overdue to redo the social contract. And all of the inequities that we have lined up here, from COVID to the economics to the racial justice issue to having to deal with the impact on our democratic process and climate change are all begging at the population right now to say we need to do something different. So it is possible that significant change can occur. And one of the things we're doing about this is messaging, and the session you and I and Elizabeth Thomas are going to be giving at noon tomorrow on that topic of how to message across a polarized political environment and how we do that, which is the heart of what the Virginia and Nashville, Tennessee is talking about. And to understand a little deeper how it is that people resonate differently to fundamental values based upon that is correlated to their political beliefs, and how we in public health tend to not do a very good job of recognizing that when we shape our messages. So that's part of that. Maybe let me kick it back to you, Dawn, to just say a minute about that brilliant thing you did, and give them the link if you get a moment, to the impact between the correlation between voting and civic engagement and individual health well-being. That's really good stuff that fits right here.
Thank you, Jean. I had a good time writing it. I did post the link into the Pathable chat for anyone who's interested in checking it out. But really what it boils down to is that civic engagement impacts health outcomes over time. So people who are civically engaged early in life, they have better wealth, higher educational achievement later in life. They have better mental health and better physical health. But the opposite is also true, that people who are not engaged have lower self-rated health. They have worse health outcomes over time, and that reinforces it. So it's like you have worse health outcomes, and so you're less likely to vote. But if you vote, you can impact the things in your community and in the society you live in that are creating all the conditions that are making you unhealthy. So, so the idea behind it is really just, being civically engaged is a pathway to health equity. And that's part of why, the 2020 election is so important, not just at the presidential level, but, we're talking about school boards and county commissions and city councils and DAs, and like anybody who's on the ballot impacts the way you live your life at the local level every day. And so having your voice heard is super critical, and it will impact your health as an individual, but also the health of your community. When you look at county health rankings or any of those other kind of ranking reports, those are some of the factors that come into play in how your county or city ranks according to health. So I would say, number one thing you can do is vote. Number two is complete the census. Both voting and the census determine the distribution of resources in your community, and resources equal power. So if you want to have a more empowered community, you have to get engaged. And then I also would say stay engaged throughout the year. Research is really strong on a connection between even doing things like community groups, sports, recreational sports, gardening clubs, churches, etc., on creating social cohesion and creating healthier neighborhoods. So even outside of election season, engaging in those kinds of activities is really critical to ensuring that your community is healthy, but also that you have better health outcomes over time. So that would be my plug. Thank you, Jean, for throwing me that softball there. Yeah. But anyone else on what would you recommend that people leave here and think about doing? And also,
I think what you're saying is absolutely right. What the two of you have said. I will say, in terms of what Virginia has given as examples, we're talking at the grass top, going down to the ground level, to the grassroots. We see sometimes preemption and the supremacy of federal law is a bad thing, but it's not always a bad thing. And there are federal laws that prohibit and address some of the inequities that we find ourselves in the midst of. And what I would say to people is if you see somebody in an institution, whether it be a nursing facility or a hospital or a school or a courthouse that is discriminating against someone who has a disability or taking actions that have a disparate impact on people based on their race, color, or national origin, file a complaint with the Office for Civil Rights. That is a facial violation of either the ADA or Title VI of the Civil Rights Act. And the complaint doesn't need to be anything fancy pants. It can just be a letter saying, this is what's happening. This is wrong. Please investigate. And once you do that, they have to investigate. They don't have the ability to say, well, we've read this and we're not going to investigate this one. And send the letter to your local newspaper and let them know that an OCR complaint has been filed against them.
Just want to double click on that, as we like to say. I like to say, good point.
Yeah.
I would say also, especially to our audience here, which is probably mostly made up of attorneys and public health professionals, is that to not just advocate for the change that we think people want, but to actually listen to what people want, especially from marginalized communities. In harm reduction, we talk a lot about meeting people where they're at, and that applies in all situations, really. Like, if you are going to be advocating for a community, their voice needs to be heard, not just what you think they want to say.
Corey, you want to add anything?
No, I agree with all of that.
So then I have another great question that came in. This one might be, I don't know, we'll see what we got here. So if a jurisdiction discloses, Jean, you might get this one.
Oh, yeah.
If a jurisdiction discloses health data to the CDC as part of their normal reporting process, and then the CDC subsequently discloses that data publicly, but the public disclosure might violate the originating state's public health laws around disclosure, how do we reconcile those differences?
Yeah. Long ago in a galaxy far away, I was the chief legal officer at Centers for Disease Control during the AIDS years, and we wrestled with that very issue. So there's sort of the traditional CDC answer, and then there's the God knows what the answer is today in this administration. That occurred regularly, where states were taken out of the COVID just for a moment. But during the AIDS wars of the 80s, the release of personally identifiable information about someone who was infected with HIV was sort of tantamount to public shaming, loss of job, and so in order to get the reporting to the states, you've got to respect that confidentiality. And there are some in any federalist system. I had a doctoral student do a dissertation on this. Surprisingly enough, there are very few limitations on what a public health officer at the local, the state, or the national level is limited to release information in an emergency situation. So sometimes you see that coming out with people that are, if you have a encephalitis outbreak in a school system and you've got to crack the small scale cell data to say the outbreak is at this school and at this, these classrooms or whatever. So there is pretty broad, flexible authority that the courts allow a health official acting with reasonable bounds of discretion under Jacobson v. Massachusetts to have flexibility to make disclosures. Now, I do a case study on this on an AIDS case, which was probably the biggest ethical mistake I made in my life, where I stuck to the letter and we did not make the disclosure because it would have violated Florida's AIDS security law. But I teach it to my doctoral students now as a mistake I made. While legally you didn't have to do it, you probably, under the state law, you weren't supposed to do it. But as you talked about, under federalism, the federal government has its own system and its own accountability. We should have made that disclosure for some ethical reasons, for some really stone cold ethical reasons. So that's the baseline. Now, what is going on now? You know, you pick up today's, USA Today and New York Times or whatever, and look at the accusations of politicalization coming down through the system now to HHS and CDC, as some of you in environmental or immigration law have seen this occur in other agencies. We're in a different ballgame here. The answer is the feds should not stomp on the toes of a state protection, privacy protection, without a really, really good reason. And I don't know that I had really seen a really, really good reason very much. The Andrew Speaker case, remember the tuberculosis patient that had multiple drug-resistant TB in the mid, around 2007, something 2008, went to Europe, then would not come in, and CDC outed him. You know, this person needs to come in, this person is infectious, is putting people at risk. So nobody questioned that. But if we're playing political games, if it smells of politics and not solid science, then you're on very shaky ground. And eventually you either further erode your institutional credibility, or you lose a political battle in the long run. Probably more than you wanted to know, but you hit my button on that one. Thank you, Virginia, whoever that was.
Did anyone else want to add to that? If not, I kind of want to go back to the first question just about what law students should know in a health law class. And one of the things that we haven't talked about is kind of non-discrimination in the context of the employment setting, like not extensively at any rate. And so while Jean was talking, I don't know why this came to me, but just the application of Section 1557 of the ACA to really basically require information in languages that are accessible to the community that you serve. So, any agency or organizations that is receiving federal funding is already required to be doing this. And so it's really interesting to see right now how under COVID, states are like, hey, look, we're responding to these disparities by putting out materials in different languages. And it's like, yeah, you were already supposed to be doing that anyways. This should just be a continuation of your normal practice. But you also want to make sure that messages are accessible and reaching people in a way that's really meaningful to them. But really going forward, I think one of the long-term things, especially for students to think about, is like, how do these things play out in practice in an employment setting for both employees and for the clients served? And I don't know if anyone else has thoughts about that.
I do want to just say something about the 1557. The 2020 regulations that were just finalized removed the notice, language notice and tagline requirements. That was the requirement in the 2016 Obama era regulations to provide notices in other languages and to provide taglines in 15 languages to let people know how to get their rights translated and how to get interpreters and translation. And one of the arguments that the HHS made when removing those is that, well, there are these other laws that already require this, so everything's okay. And that is true. Other laws do require it, but they don't entirely overlap with what 1557 required and what the 2016 regulations did to implement 1557. So I think that, there's litigation underway to enjoin the 2020 regulations. It has been partially successful in a case in the District of Columbia, the Whitman Walker case. It's being litigated right now in the Southern District of New York. Our office, along with some other offices, the National Health Law, is filing an amicus brief that is explaining the importance of the 2016 language access protections. Also from an employment context, pointing out that the Bostock decision that the Supreme Court just reached with respect to LGBTQ and rights and sex discrimination should apply equally in the 1557 context to make what the federal government did illegal, which was to remove those protections for those population groups. I would be happy to provide a copy of our amicus brief and any other briefing in those cases to anybody who would like it for them.
Great information and add on to that. Any other thoughts on that topic? Just kind of thinking about the employment context from your perspectives in COVID-19 and even students going back to campus, not just learning, but also like their experience as students going back to campus. I see that is not one that is sparking a ton of interest, which is totally cool. So, so we had a question that came in during the plenary that I'm going to throw to you all because I thought it was interesting and we didn't have time to get to it, but it was, how do we dismantle facially neutral laws that perpetuate systemic racism? That might be a deep question, but you might have an example. Jane, are you going to go? Yeah.
Yeah, I have a couple of thoughts about that. I think one thing that needs to happen is that Title VI, it needs to be amended to make it clear that people can enforce Title VI when policies have a disparate impact on people on the basis of race, color, or national origin. The U.S. Supreme Court, in an opinion written by Justice Scalia, has interpreted Title VI to only apply to intentional discrimination. For many, many years, it always before that, it had applied to both intentional and disparate impact. And so now only the federal government can enforce a disparate impact claim when it comes to racism in federally funded settings. So I think that would be number one. And I realize that it's not answering the question, it's going back behind it to make it into a different question in the first place. But that's certainly somewhere as a lawyer that I would want to start. And remember, in the disability context, I realize the question was a race-based question, but for disability discrimination, which is also prevalent out there, you don't need to prove discriminatory animus or discriminatory intent or anything like that if the result of your action is that a person is facing a serious risk of institutionalization. That factor is in and of itself discrimination under the Americans with Disabilities Act.
Anyone else have a thought on that? I was thinking about housing, and I'm not a housing expert, but I think about local zoning, for example, and restricting affordable housing units and people blocking the development of those units that really there's an opportunity to push your local councils or commissions on adopting more inclusionary zoning ordinances, because those, you know, those are facially neutral, but you know, they impact Black and Brown communities more significantly.
Yeah, I mean, I would say criminal justice reform, drug policy reform, you know, I mean, almost by definition, any law that is facially neutral, but in practice is used, you know, in a racially or economically discriminatory way, you know, repealing or modifying that law should have, you know, should help address those disparities. It's not always true. You know, we know, for example, you know, the District of Columbia decriminalized marijuana, making it difficult to arrest people for simple possession of marijuana. Marijuana arrests did go down, but they were about 90% people of color before, and they're about 90% people of color now. So the sheer number went down, and that's very good. You know, that's great. We've got fewer people with records and fewer people getting jammed up in the system for something that.
You know what, on that one, Corey, again, sort of looking behind it, what may be going on there is the way that the decision to stop someone is made in the first place. Mm-hmm. And then once you stop the person to use the tactics that you as a police officer are taught to use to be able to expand your search.
Well, sure. I mean, well, policing is designed to police poor people in poor places, right? I mean, you know, it's a lot easier to find somebody, you know, smoking a blunt on their stoop, you know, than it is someone, you know, you know, whatever, in a Georgetown townhome or whatever, you know. So sure, there's a lot going on there, but you know, so I think it's, I mean, you know, I'm not sure actually what the conclusion to draw from that is. I mean, it is still a very racially discriminatory law, but you know, you also have thousands of fewer people being cited and arrested each year. So it's not that the change wasn't worthwhile in and of itself. It just tells us, I think, that more work needs to be done. You know, it's not just changing the law, as you're saying, Jane, it's changing the culture, it's changing the practice, it's changing the, you know, it's really thinking deeply about this question of what are we doing here? What is our goal as a police department? You know, is it to make arrests? You know, I think a lot of police departments think that is their goal. It's a very dumb goal. But if nobody's telling them, no, actually, you know, your goal is to improve, you know, the health and safety of your community, and you're thinking about making an arrest, you should be considering, is arresting this person actually going to improve the health and safety of this community? You shouldn't do it. And you align the incentives, you know, along those lines. But that's, you know, that's hard. That takes a lot of work. And I think maybe that's, you know, maybe that's the, the depressing big picture answer that we all know is true. You know, changing laws is important and good, and winning court cases is important and good, you know, but at the end of the day, we really need to change the way people are thinking about the purpose of those laws.
Right.
Another thing to teach those law students, you know?
Yes.
Yeah, I mean, if a law on a piece of paper is facially neutral, but the results are not neutral, it's not the law. It's whatever we're bringing into our interpretation of that law. That is the problem.
Yeah. Ooh, this is great. I love it. So we have about 10 minutes left, which I think we could do 2 more questions probably. We did have another one come in. That's something that has come up as a terrifying reality for practicing public health staff, or criminal liability precedents set based on some of the Michigan cases. It's a good one. Not sure if it raises to your level of large-scale national impacts. I think it does. Jean, you want to start us off on that?
Well, I mean, there's sort of 2 sides of it: liability of the health officials, and then liability of those that are threatening the health officials. So to sort of take the second one out of the way first, our Southeastern Regional Office, and Kathy Hoke is collaborating with, I believe, ASTO and NACHO to help put together sort of a playbook to deal with health officials that are being threatened. And I think we're about ready to have something rolled out, but you can go to our website if you've got questions on that piece of it. Then check with Kathy Hoke in our Eastern region out of Baltimore because they're working on that. I think we have a session in this on emergency standards of care, which is sort of the kernel around criminal and civil liability of health officers in COVID that are taking action or not taking actions. And our Mid-States region out of Ann Arbor has done a lot of work on that. Denise Chrysler and Colleen Healy-Bufides and Jill Bernstein have done a great deal of work on the lessons that came out of the Flint water crisis and the criminal charges that were brought there. So there's a whole body of law on that. I'm not expert, but clearly there, and right now I've been a little more focused on the issue of what do you do to health officials that are being threatened, who are wanting to enforce, an order for personal protective equipment or testing or whatever. So that's sort of the two sources we've got in our network on that from two of our sister regions.
Anyone else want to comment on that? I would say, from my perspective, one of the things is, state, local health officials, those are often really political positions. They appoint people, so they're also in somewhat political positions, and they're in a position to make decisions that are, trying to balance the interest of their administration with the interest of public health, to go back to the statements earlier about science-based action. And so it's really important, here's a good example in Flint of where engaging the community and pulling the community into some of those decisions or having some kind of community participatory process in place might have influenced the outcome in some way. The flip side of that, of course, is that now we know the problem is very public, and the community there is still being failed by leadership in many ways. So that goes to accountability also on the back end. Like, now that we know that a problem exists, and we need to actually take the steps to ameliorate it, and then and when it isn't working, change our course of action. So that would be, my comments on the kind of actions that people are taking. I don't know if anyone else wants to add. I think we had one more thing come in. And Sarah shared that we do provide legal technical assistance on public health issues like these. So if you're in a jurisdiction or community and you have questions that are very specific that you are looking for assistance on, you can reach out and request assistance from us. And Sarah posted that link in the chat box. Any other, so we have just a few minutes left to wrap up, and I want to make sure we put out any last comments there.
Yeah, Julia Kosich, I apologize. I could not pull that link up with too many screens here, but I can send you the link to the New York Times Sunday Magazine piece of about 6 weeks ago. That is sort of the textbook way of teaching the law class on public health law and federalism and the failings that have occurred. So I will send that to you separately. Apologize, I couldn't pull it up while I was here. So I guess we're at a wrap. I want to thank everybody, Jane and Amy and Corey and Dawn. You had a long day, Dawn. You were kicking the show off at noon today. And we got another gig. We got 2 gigs tomorrow, actually.
2 gigs.
I get 2 gigs with Dawn tomorrow. One to talk about messaging in a polarized environment, and then with Dawn to talk about how further thoughts of dealing with health equity and social justice. So anyway, Thank everybody. Please look at the little link below and do the take the survey. And any comments or thoughts you have, we will appreciate it very much. And we will see everybody at high noon tomorrow.
Thanks, everyone.
Thank you, guys. Appreciate it.